Please listen carefully.
Hello, and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. The show notes there, there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Before we get into the bulk of this episode on Midazolam, I just want to say I've had a look at some old episodes and realised that the classify and cry and define or die elements have kind of dropped to the wayside a little bit. And I think they're quite fun, and it's also quite important from just answering questions in the exam perspective. So I'm going to make some slightly ridiculous voiceovers so that when we come to a define or die or classify and cry moment, it gets marked in the episode. We know a little bit of drama is good. But interestingly, if anyone has any other adages, figures of speech, or idioms like this that are relevant to sort of anaesthetic practice overall, I'm just thinking of something like, is there one that says that you should probably get really prepared, other than the 7 Ps, proper and prior preparation prevents piss poor performance, that might come from other parts of the world? Is there a Norwegian define or die, or an Australian classify or cry? So if there is one, email me, and it'll probably make it into the show. Anyway, that's all tickety-boo and great. What about benzodiazepines? We're going to focus chiefly on midazolam today. There are a bunch of other benzodiazepines: diazepam, temazepam, lorazepam, alprazolam, ad infinitum-ish. But midaz is the one that we tend to see in the cupboards, and is the one we use from a general anaesthetic and sedation periop perspective. So midazolam, what is it? It's an imidazole benzodiazepine. Benzos were first synthesized in the 1950s, and diazepam actually saw clinical use first in the 1960s. Midazolam is a clear, colourless solution in 1, 2, or 5 milligram per mil preparations of midazolam hydrochloride. Importantly, folks, inadvertent use of the wrong concentration of midazolam for sedation is a never event in the UK. That sometimes comes up in exams. Molecular weight: 325.8 grams per mole. I'm sure you're writing that down. Mechanism of action of midazolam: it potentiates neural inhibition by mediating the effects of GABA. It acts via a specific binding point for GABA transmembrane proteins in cortex, midbrain, spinal cord, etc. We're going to talk about in reasonable detail how GABA receptors behave. In vitro, midazolam also seems to have some opioid receptor agonism at the kappa opioid receptor. Might fit with how it has a degree of analgesic effect if you give it intrathecally, but this is niche stuff. What do we use midazolam for? We use it in induction of anaesthesia. We use it for sedation. We can use it as a pre-med to get someone down to the anaesthetic room. Quite classically used in kids in the UK. 0.5 milligrams per kilo in some orange juice, up to 15 milligrams. We sometimes reach for it to induce amnesia. Patients sometimes benefit from benzos if they have muscle spasm. And it is an anticonvulsant in a pinch, although lorazepam is the one that's more studied for that. Comparing it to lorazepam and diazepam, midazolam has the shortest recovery profile as well, and that's perhaps why we end up using it more. Delightful dosing strategies. So I think everyone kind of just operates in 0.5, 1, 2, 10 milligram per patient doses. If you're being particular, 0.07 to 0.1 milligrams per kilo. So in a 75 kilo patient, you could give them 5.25 to 7.5 milligrams. I don't think anyone bothers with that. We've noted the pre-med ped dose, 0.5 milligram per kilo. You can give up to 1 milligram per kilo, up to 20 milligrams, but I think there might be other better options like dexmedetomidine, which is going to be another episode later. Up the nose, dexmed up the nose, great. Side effects. Again, remember we're on the pharmacodynamic side of our conversation, which is what it does to the person, not what the person does to the drug. Side effect profile: midazolam. Cardiovascularly, just sneaks your blood pressure down a tad, is what the argument would be. Systolic down by 5%, diastolic down by 10%, so really barely a whiff. It might reduce your systemic vascular resistance by 15 to 33%, but it speeds your heart rate up by about 18%. So it sounds very accurate. Someone's done a very particular study here. Respiratory respiratory effects, so it does drop your tidal volume. However, it also causes a contrary increase in respiratory rate, so your minute ventilation remains about the same. But it also causes apnea, so if you give too much, then obviously your respiratory system is in a pickle. Midazolam has a negative effect on the dose-response curve for carbon dioxide though, so in a patient with sleep apnea, CO2 retaining COPD, then it's probably not the drug to reach for unless you're intubating and sedating a patient and taking them to ITU, knowing that you're not going to wake them up today. Then you might use it as a co-induction agent. CNS effects of midazolam. Now, you guys can guess this. Hypnosis, sedation, anterograde amnesia, i.e. you can't form new memories, but memories that have already been formed are going to stick around. One of my colleagues at work had mentioned that when they had a anaesthetic for a joint, they asked their colleague, like, just make sure I don't remember anything, and just give me some midaz to kick off with. Had a midazolam et general anaesthetic approach, and his first new memory following his joint procedure was when he was sat on the ward with a cheese sandwich in his hand. That's the first memory he formed. Obviously, his brain was working enough to request a cheese sandwich and to begin eating cheese sandwich. I don't know how many bites were out of that sandwich. I don't think he looked specifically, but it just demonstrates that, a patient can be walking around quite functionally, but not yet be forming memories. It's crazy, really, isn't it? It drops cerebral blood flow and also cerebral metabolic consumption of oxygen in a dose-related manner, and it dampens the adrenergic response to stress, but it doesn't do anything about cortisol secretion, etc. Righto, kinetics, pharmacokinetics. This breaks down, guys, remember, into absorption, distribution, metabolism, and elimination. If ever you get a question that says, talk about the pharmacokinetics of, break it down into that, and then you're going to probably bag some points. Absorption of midazolam, oral bioavailability 44%, distribution, so it's 96% protein bound in the plasma. So you can imagine then that small changes in protein binding leads to large free fraction agent availability. So in someone with low albumin, your liver cirrhotic patient, as we all know, benzos seem to work really well and last a really long time. This is why. Steady state volume of distribution 0.8 to 1.5 litres per kilo. Now you might say, hey, what's the pKa of midazolam? Well, we know that midazolam behaves a bit strangely because it's another one of these tautomers. Although in the previous episode we point out that midazolam is not quite really 100% a tautomer. If you're in an exam and it says what sort of isomerism does midazolam have, and the option is tautomerism or geometric isomerism, blah blah blah, it's just tautomerism. It's just being finicky. So it's tautomer, we're going to say it. In its water-soluble form, in that ampule, where its pH is less than 4, it's nice and happily water-soluble, and that's because there's a ring that is open in the molecule. Chuck it into someone's plasma, pH now is 7.4. That ring closes, it makes it very lipid-soluble, and it piles across the blood-brain barrier. Great. Now, how is midazolam metabolized? I took 4 goes to say that. So it's near complete metabolism in liver. It is CYP3A4 metabolized into 2 metabolites, alpha hydroxy midazolam and 4-oxymidazolam. Now, the alpha hydroxy midazolam is potent. However, they are promptly glucuronidated into inactive metabolites. So you could say, well, it has active metabolites, but then you could also say, yeah, but then they just get glucuronidated, so it's really just academic. Someone called Greenblatt in the late 1970s and early 1980s was doing some experiments, and actually it's quite interesting. Who knows if it was because there was an issue with the experiment or not, but old blokes and young lads, old blokes cleared midazolam more slowly than the young lads, whereas elderly ladies and young lassies showed no difference in their clearance of midazolam. I do know that we are taught that old folks don't clear benzos as well. Now, perhaps this is actually based on old folks with low albumin, so they've got a greater free fraction and therefore they have higher potency of effect. Who knows? I think I would still be giving only a smidge to an old person and perhaps be a bit more liberal in a younger person. How is it eliminated? Well, as you can imagine, using your powers of imagination, you can know that if something has been beautifully glucuronidated, it is delightfully water-soluble. And how do we get rid of water-soluble molecules? Kidneys. Cleared through the kidneys. Clearance is 5.8 to 9 mils per kilo per minute. Renal impairment has minimal effect on the clearance of this. Elimination half-life 1.5 to 3.5 hours. In critically ill folk, the elimination half-life goes up, but that would suggest to me that it's actually perfusion of kidney-related clearance as opposed to like active excretion. So, other points of note, a midazolam pre-med reduces your MAC requirements by 15%, but remember guys, it's only going to reduce those MAC requirements by 15% whilst the drug works. It's not just like, my whole operation, my 18-hour laparotomy. It's okay, folks, we can go with a MAC of 0.6. I gave them Midazolam at the start. So, it probably just means it's quicker to get them asleep at the start and you have a lower chance of having accidental awareness under general anaesthesia in that trip to theatre from the anaesthetic room phase. When do I use Midazolam? For slightly hairy intubations where you don't want to mess with blood pressure too much, I'll give Midazolam. I give Midazolam if I'm giving someone ketamine, and I'll give them a really big dose of Midazolam if it's the post-cardiac arrest or we're not going to wake them up today sort of patient, whereby you really want to chill them out as best you can, but you don't want to be smashing them with buckets of propofol, so they get Midazolam and fentanyl, etc. Where have I seen it reached for? So I've seen it reached for during that awful cardiac arrest CPR situation when you're doing CPR on often a fittish person and they start going, ow, no, and you stop CPR thinking they're conscious and that maybe they've got output, and then they just go and lose consciousness again. It's very unpleasant for all involved, and it's challenging to figure out if they're rosked or you're just doing excellent CPR. And if you're in the excellent CPR and they've got VF and it's just a bugger and it won't zap back to something more sufficient, and they need, your 300 of amiodarone, your 150 of amiodarone, your 4 grams of magnesium, and then you think, let's give another 2 grams of magnesium. Them not returning to consciousness after that is not the end point of your CPR. Your end point of your CPR is either they've got a pulse again, oh, look, they're not waking up. Well, they've just had loads of CPR. That doesn't really mean anything at that point. Or they're so metabolically deranged, they've got no hope. So the next step in that thought process is, are they forming memories? Are they going to get PTSD from those formed memories? Or is this just scant perfusion of their brain and we might be hearing a no, but we might not? It's hard to really tell. I haven't decided if in that situation I would or would not give the patient Midazolam. It's not in ALS, but then ALS, remember folks, is not the be-all and the end-all of resuscitation. It's a guideline. It misses a load of nuance because it has to be simple enough to teach people in either 2 days or 1 day with a load of e-learning. That's not the same as a clinician with donkey's years of experience, but it's a great place to start to get people skilled up in the technical procedural aspects of CPR instead of the wider doctory aspects of resuscitation. I think it's a crying shame that anaesthetists are coming off of the cardiac arrest bleeps in hospital, because whilst a lot of those cardiac arrest bleeps are in old folk who should have had DNARs, there'll be a subgroup of those people who actually might survive if they had blisteringly effective CPR and peri-arrest care that your experience might deliver, whereas a ward, a junior med reg, some foundation doctors following the ALS algorithm, which is deemed to be this, gold standard thing, is perhaps not the best thing for the patient. It's a pity. It really is. Anyway, getting carried away here. Antidotes for Midazolam. Say someone's accidentally done the Never event and they've given a bucket of Midazolam instead of a thimble. Then flumazenil, our benzodiazepine receptor binding molecule that antagonizes the receptor, is a great choice. Interestingly, physostigmine, which is an anticholinesterase, can also alter the sedating effects of benzodiazepines and wake people up. Cool. Not something I knew about before, but people are going to use flumazenil. But why don't we just use flumazenil on anyone who's come to A&E? Tammy or Tommy, it's a Friday night, they've taken a load of alprazolam, that's Xanax, and you think, well, we could just give them some flumazenil, wake them up, send them on their way. Because they might have been taking other things beyond the Xanax, alprazolam. That Xanax in their system might be stopping them from actually seizing like it's the 31st of December 1999. So it's better just to let those drugs cook off, clear out, keep them hydrated, warm, safe, breathing, oxygenated, etc. Always look at tox space. So moving on from the section on Midazolam and Midazolam kinetics and pharmacodynamics, we mentioned GABA receptors here, and GABA, etc., etc. We just probably need to make sure we remember what the heck that is. So GABA, we've said GABA a lot. GABA, gamma-aminobutyric acid. It's a endogenous neurotransmitter that is incredibly important when it comes to CNS activity. The receptor we're interested is the GABA-A receptor. This is a 5-unit, i.e. pentameric, membrane-bound group of proteins which have a central chloride channel. There are a bunch of subtypes of GABA-A receptors not doing that. What happens when GABA binds to a GABA-A receptor? Well, it alters the shape shape of that receptor, opening that chloride pore, and lets chloride ions into the cell. Chloride ions, as we all remember, folks, are negatively charged. They are anions. An ion, a negative ion. That's how I remember it. If you make the cell more negative, it's harder for it to depolarize when an action potential comes along and prods it. Therefore, you inhibit transmission. Now, more specifically, you find clusters of these GABA A receptors on the postsynaptic membranes of neurons. That means that when you modulate that, increase the chloride influx, you end up with postsynaptic negative environment. So those neurotransmitters that are crossing the synaptic cleft have a higher threshold before they're going to communicate downstream, so you'd need a supranormal amount of neurotransmitter being ejected from that nerve to trigger downstream ongoing communication of that action potential. What binds to a GABA A receptor? Well, we've said GABA, gamma-aminobutyric acid, and there's a specific home on that receptor for that ligand, but then a bunch of other stuff binds to it, but it doesn't bind to the GABA site. So benzodiazepines bind to it, general anaesthetic agents seem to bind to it, and ethanol binds to it. And these all allosteric to change the shape of, modulate this receptor. Those agents tend to make this receptor more likely to be open and therefore let chloride ions in, and therefore make it harder for transmission to occur. Now you're probably thinking now, GABA A, what does that mean? Well, it means that GABA B must also unfortunately exist, otherwise it would just be called a GABA receptor. GABA B is a G protein coupled membrane bound protein that we're not interested in, and no one tends to be interested in for anaesthetic purposes. So let's just have a bit of a thought experiment here. Imagine if you took away someone's ability to synthesize GABA. They're going to be rattling. They're going to be all disinhibited and really easily communicating signals down their neurons, and it's all probably a bit of a mess. They'll probably have a seizure. There are some rare diseases which can involve this, but interestingly, pyridoxine is critical in the synthesis of GABA, gamma-aminobutyric acid. If you have a pyridoxine deficiency or a defect in one of the enzymes that's involved in the pathway of converting pyridoxine to GABA, you'll end up in a bad way. Now, you can treat those seizures seemingly with anticonvulsants, but most of the time, if you supplement the patient with pyridoxine or the relevant derivative, the problem goes away. Huntington's disease seems to be partially associated with a lack of GABA in the striatal projections that go to your globus pallidus. Remember, globus pallidus is part of your basal ganglia. But now, we've all seen patients with a relative deficiency of GABA. Yes, that's right. Our dear population of people who drink too much alcohol too frequently. The mechanism of this is booze modulates GABA, means that your neurons are all suppressed. Over chronic alcohol consumption timeframes, your neurons upregulate themselves to try and contend with this suppression that the alcohol causes. That returns you to a modicum of functioning. You don't seem drunk anymore, and that's because your neurons are countering the booze. You remove the booze, and then your neurons have the brakes taken off of them because they were fighting to be active, and now you've taken away the thing that they were fighting against. So they're really jazzed up. So you end up sweaty, agitated, delirious, hallucinating, confused, hypertensive, tachycardic, and ending up with seizures, delirium tremens, etc., being pinned down by all the on-duty police officers in North Wales whilst getting a ketamine anaesthetic on the floor of AMU. And this is why benzodiazepines are an effective treatment for alcohol withdrawal, because they replace the role of the alcohol. But that makes me think that if a patient with acute benzodiazepine withdrawal was on your ward, well, you could treat them with alcohol. Arguably, you could also just treat them with benzodiazepines. But, you can have a twinkle in your eye as you suggest that to the consultant. So I hope you have enjoyed that episode, folks. I hope you have a nice weekend next week, where we're going to probably do dexmedetomidine or clonidine, one of the two. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.